I need to talk to you about something today that I believe every single person over 65 who takes medication every day needs to hear, not because I want to frighten you, but because what I am about to share is information that could genuinely protect one of the most important organs in your body, your kidneys. And it is information that in a standard 15-minute appointment, there is simply never enough time to explain properly. I am Dr. Daniel Chen, and today I'm going to walk you through 9 common medications that millions of seniors over 65 take every single day without knowing that those medications can quietly and progressively damage their kidneys when not properly monitored. Now, before I go any further, I need to say something clearly, and I need you to really hear this. Do not stop any medication based on what I tell you today. Every medication I am going to discuss was prescribed for a real reason, an important reason, and stopping suddenly without speaking to your doctor first can cause serious harm. What I want you to take away from this video is not fear, it is knowledge. The knowledge to ask better questions at your next appointment, to make sure the right monitoring is happening, and to understand what your kidneys are dealing with every single day. So let us start with something important that most people over 65 have never been told. By the time you reach 65, your kidneys have already lost a significant portion of the filtering capacity they had at 40. Kidney function naturally declines by approximately 1% per year after the age of 40. This means that by 65, your kidneys may be filtering at only 75% of what they could do 25 years ago. And by 75, that may have dropped further still. This matters enormously because medications that a younger adult can tolerate without any kidney consequence can place a real burden on kidneys that are already working with reduced capacity. The kidney's ability to filter medications, process their metabolites, and excrete their byproducts is reduced, which means drugs stay in the system longer at higher concentrations and with greater potential for kidney toxicity than they would in a younger person. Taking the same dose of the same medication. Now, let us go through the 9 medications one by one. The first is ibuprofen and the entire family of medications called non-steroidal anti-inflammatory drugs, or NSAIDs. This includes naproxen, sold as Alev, diclofenac, aspirin in anti-inflammatory doses, and many others. NSAIDs are available without a prescription, which is part of what makes them so commonly used and so commonly misunderstood in terms of their kidney risk. Here's what they actually do. Inside the kidney, there are tiny blood vessels that maintain pressure. Inside the filtering units called glomeruli, these blood vessels are regulated by hormone-like substances called prostaglandins. NSAIDs work by blocking the production of prostaglandins throughout the body, which is how they reduce pain and inflammation. But in the kidney, prostaglandins play a critical role in keeping the blood vessels that supply the filtering units open and adequately dilated. When NSAIDs block prostaglandin production, those blood vessels constrict blood flow to the kidney drops, and the filtering units begin to receive less blood than they need to function properly. In a young, healthy person with fully functioning kidneys, the kidney has enough reserve capacity to manage this drop in blood flow without lasting harm. But in a person over 65 whose kidney function is already reduced, this constriction of blood flow can tip the balance from manageable to damaging. And when NSAIDs are combined with other medications like diuretics or ACE inhibitors or ARBs, the risk multiplies significantly, creating what kidney specialists call the triple whammy, a combination that can cause serious acute kidney injury within days. The second medication is hydrochlorothiazide and the class of medications called thiazide diuretics. Diuretics work by making the kidneys excrete more sodium and water, reducing blood volume and lowering blood pressure. In principle, this sounds entirely safe, but in older adults whose thirst sensation has already diminished with age, diuretics can cause significant dehydration without the person feeling thirsty enough to compensate. And dehydration reduces blood flow to the kidneys in the same way that NSAIDs do. through a different mechanism, but with the same consequence: reduced delivery of blood to already stressed filtering units. Additionally, thiazide diuretics cause the kidneys to excrete potassium, along with sodium and water. This can lead to low potassium, called hypokalemia, which affects not just the kidneys, but the heart. And in people over 65 who may already have some degree of heart vulnerability. Low potassium is not something to be dismissed lightly. The third medication is lisinopril, and the entire class of drugs called ACE inhibitors, including enalapril, ramipril, and benazepril. ACE inhibitors lower blood pressure by blocking a hormonal system that constricts blood vessels inside the kidney. This reduces the pressure inside the filtering units, which in many people is genuinely protective, particularly in diabetics, but in older adults who already have reduced kidney function or who have any narrowing of the arteries that supply blood to the kidneys. This reduction in filtering pressure can go too far. The filtering units begin to receive insufficient pressure to do their job. Waste products begin to accumulate in the blood. Creatinine rises. And in serious cases, acute kidney injury develops. ACE inhibitors also cause the body to retain potassium, which, as I just described, can build to dangerous levels in older adults with reduced kidney function. If you take an ACE inhibitor and you have never had your potassium level or your kidney function specifically checked since starting it, please ask your doctor for those tests at your next appointment. The fourth medication is Losartan, and the class of drugs called angiotensin receptor blockers, or ARBs, including valsartan, olmesartan, and irbesartan. ARBs work through a very similar mechanism to ACE inhibitors and carry almost identical risks to the kidneys in older adults. They are often prescribed as an alternative to ACE inhibitors when patients cannot tolerate the dry cough that ACE inhibitors commonly cause, but the kidney risks, the potassium retention, the reduced filtering pressure, they are essentially the same and require the same monitoring. What I want to specifically flag about ARBs is that they are increasingly prescribed in combination with ACE inhibitors or with direct renin inhibitors in what doctors call dual renin angiotensin system blockade. This combination was once thought to provide superior kidney protection. But the OwnTarget trial, a large clinical study published in the New England Journal of Medicine, found that this combination actually doubled the risk of acute kidney injury in the patients studied and significantly increased the risk of dangerously high potassium. Major nephrology guidelines now specifically recommend against this combination if you are taking both an ACE inhibitor and an ARB simultaneously. Please bring this up with your doctor at your very next appointment. The fifth medication is amlodipine, and the class known as calcium channel blockers. Amlodipine is one of the most widely prescribed blood pressure medications in the world, and for most people, it is well tolerated. But calcium channel blockers have a specific effect on kidney blood flow that older adults need to understand. They dilate the arteries that bring blood into the kidney's filtering units without equally dilating the vessels that carry blood out. This creates a situation where more blood enters the filtering units than can comfortably leave, increasing the pressure inside them in a younger adult with healthy kidney tissue. This increased pressure is managed without significant consequence, but in adults over 65 with already compromised kidney tissue, this elevated intraglomerular pressure over months and years can accelerate scarring and long-term kidney damage. Amlodipine also commonly causes fluid retention and ankle swelling in older adults, which often leads doctors to add a diuretic, creating a combination that each individually affects kidney function and together requires careful monitoring. The sixth medication is furosemide, sold as Lasix, a loop diuretic that is more powerful than the thiazide diuretics I described earlier. Furosemide is commonly prescribed for heart failure, fluid retention, and high blood pressure. In older adults, it is a genuinely important medication for the conditions it treats, but it is also one of the most potent drivers of dehydration in older adults. When the kidneys are pushed to excrete large amounts of fluid rapidly, blood volume can drop significantly, reducing kidney perfusion to levels that cause acute kidney injury, particularly in hot weather, or when the person is not drinking adequate fluids to compensate. Furosemide also causes significant potassium and magnesium losses, both of which need monitoring and replacement. When furosemide is used long-term in older adults, the seventh medication is metformin, the most commonly prescribed medication for type 2 diabetes. Metformin itself does not directly damage the kidneys. I want to be clear about that. But it has a critical relationship with kidney function that every senior over 65 taking it needs to understand. Metformin is processed and excreted entirely by the kidneys. When kidney function is normal, this happens without any problem. But when kidney function falls below a certain threshold, metformin accumulates in the body rather than being excreted. And at high accumulated concentrations, it can cause a rare but very serious and potentially fatal condition called lactic acidosis, where lactic acid builds up in the blood to dangerous levels. This is why metformin is contraindicated or requires dose adjustment when kidney function falls below certain thresholds, and why regular kidney function monitoring is mandatory for everyone over 65 taking metformin. If you have been on metformin for years and you cannot remember the last time your kidney function was specifically checked, please call your doctor tomorrow and ask for that test. It is a simple blood draw, and the information it provides is not optional. For someone your age, taking this medication, the eighth medication, is certain antibiotics, specifically a class called aminoglycosides, including gentamicin and tobramycin. These antibiotics are used in hospitals to treat serious bacterial infections, and they are genuinely effective for that purpose, but they carry a well-recognized and significant risk of kidney toxicity called nephrotoxicity and ototoxicity. Damage to the inner ear. The risk of aminoglycoside kidney damage is substantially higher in older adults than in younger patients because the kidneys have less reserve capacity to manage the toxic burden. If you are ever admitted to hospital and treated with an antibiotic, you should be aware that not all antibiotics carry the same kidney risk, and it is entirely reasonable to ask your treating doctor whether the antibiotic being used requires kidney function monitoring during treatment, and whether your kidney function was checked before the dose was chosen. Dosing of aminoglycosides must be adjusted for kidney function and for age, and in older adults, this adjustment is critically important. The ninth medication is contrast dye used in imaging procedures such as CT scans with contrast and certain cardiac procedures, including coronary angiography. This is not a medication you take at home, but it is something that an enormous number of seniors over 65 are exposed to, often without being told about the kidney risk. Contrast dye is processed and excreted by the kidneys, and it can cause a condition called contrast-induced nephropathy, where kidney function drops significantly in the days following the procedure in most younger adults with healthy kidneys. This drop is temporary and kidney function recovers, but in older adults with already reduced kidney function, or with diabetes, or with existing chronic kidney disease, contrast-induced nephropathy can cause permanent and significant additional kidney damage. This is why, before any imaging procedure that involves contrast dye, your kidney function should be checked, and the risks should be discussed with you specifically, given your age and your existing kidney function. If you are scheduled for a CT scan with contrast or a cardiac catheterization, and your doctor has not mentioned checking your kidney function first, it is completely appropriate to ask, has my kidney function been checked before this procedure? And is the contrast necessary? Or is there an alternative imaging approach that does not require it? Now let me tell you, the monitoring that every person over 65 taking any of these medications should be receiving at minimum. Kidney function should be checked through a blood test at least once every 6 months. If you are on an ACE inhibitor, an ARB, a diuretic, metformin, or any combination of these, this blood test called a basic or comprehensive metabolic panel. Checks your creatinine level, your eGFR, which is estimated glomerular filtration rate, the most accurate measure of how well your kidneys are currently filtering, your potassium level, your sodium level, and your blood urea nitrogen. These are not complicated tests. They are a simple blood draw covered by Medicare and most insurance plans. If you have been on any of these medications for years and you cannot remember the last time these specific numbers were checked, please call your doctor's office tomorrow morning and ask for this panel. Tell them you are over 65, you are on these medications, and you want your kidney function and electrolytes checked. That is a completely reasonable request, and a good doctor will take it seriously. Now let me also give you the warning signs that your kidneys may already be under stress. Watch for swelling in your ankles, feet, or legs that has worsened recently. Watch for changes in urination, more than usual, less than usual, or urine that appears foamy or frothy. Foamy urine is a sign that protein may be leaking into the urine, which is an early warning sign of kidney damage. Watch for persistent fatigue that does not improve with rest, a feeling of pressure or discomfort in the lower back, on either side of your spine, difficulty concentrating, or brain fog that is gradually worsened, and unexplained nausea or loss of appetite. If you are experiencing any combination of these symptoms while taking any of the medications I have described today, please bring this to your doctor without delay. Do not wait for your next scheduled appointment. Call and go in. Let me bring everything together now. Your kidneys lose approximately 1% of their filtering capacity every year after 40. By 65, they are working with significantly less reserve than they had in younger years. 9 common medications taken by millions of seniors every day can place additional burden on those already reduced kidneys when not properly monitored. NSAIDs like Ibuprofen and naproxen reduce blood flow to the filtering units. Thiazide diuretics like Hydrochlorothiazide can cause dehydration and dangerous electrolyte imbalances. ACE inhibitors like Lisinopril can reduce filtration pressure too far and cause potassium buildup. ARBs like Losartan carry essentially the same risks and should never be combined with an ACE inhibitor. Calcium channel blockers like Amlodipine can increase intraglomerular pressure over time. Loop diuretics like furosemide can cause rapid dehydration and electrolyte depletion. Metformin requires regular kidney monitoring because it accumulates when kidney function declines. Aminoglycoside antibiotics carry significant nephrotoxicity risk that is amplified in older adults, and contrast dye used in imaging can cause permanent kidney damage in older adults. With already compromised function, the answer is not to stop these medications. The answer is to make sure you are being properly monitored while taking them. Kidney function and electrolyte checks, at least every 6 months. A medication review that considers all of your medications together, not just individually, and an honest conversation with your doctor about whether every medication you are taking is still necessary at its current dose. Given your current kidney function, you deserve that conversation. And now you have the knowledge to ask for it. I am Dr. Daniel Chen. If this video gave you information that you did not have before, please share it with someone over 65 who takes medication every day and has never been told about the kidney risks I have described today. Subscribe to this channel for weekly videos made with genuine care for older adults who deserve real information about their own health, and leave me a comment below. Tell me which of these medications you are currently taking and whether your doctor has ever specifically discussed your kidney function in relation to them. I read every single comment, and I genuinely look forward to hearing from you. Take care of your kidneys. They filter 200 liters of blood every single day without rest, without complaint. They deserve your attention before the damage becomes irreversible.